Okay, let's start with diagnosis, history, and exam. I like to categorize the pertinent points of history exam to different categories: common symptoms of leukemia and leukemia-specific symptoms. Let's think about the common symptoms of leukemia first. Leukemia is an infiltration of the bone marrow with tons of white blood cells. This goes to the expense of red blood cells and platelets. Even the white blood cells that there are in the bone marrow are not functional, meaning they're not white blood cells that are terminally differentiated and they're not able to fight infections. Given that all three cell lines are not functional and can't do the job that they normally do, you have symptoms accordingly. Okay, so three classes of symptoms. Okay, three different kinds of badness that can happen. First, your red blood cells, okay, will give you anemia. And your patient is going to be very fatigued, is going to be pale, and can even develop quite significant shortness of breath. Secondly, low platelets. Okay, thrombocytopenia can cause bleeding. Many of acute leukemia patients also have a complication that we're going to talk a lot about called DIC, disseminated intravascular coagulation, which can lead to bleeding as well as clotting. Lastly, infection. Our classic febrile neutropenia. If a patient is neutropenic after chemotherapy, which would be absolute neutropenia, or he's neutropenic even with a very high blood cell count, because those white blood cells are not functional, called functional neutropenia, in either case is prone to lots of infections, including pneumonia, diarrhea or typhlitis. Typhlitis is another word for neutropenic colitis. All kinds of skin and soft tissue infections, including cellulitis, abscess, line infections, as well as mucositis. So it's always important to ask your patient, are you short of breath? Are you fatigued? Any recent bleeding episodes? And any recent infections? Do you have a cough, a fever, sputum production, any diarrhea or abdominal pain, any new rashes or cellulitis? And do you have pain in your throat? Okay, so those are the most important symptoms. There's some leukemia type-specific symptoms to point out. For AML, mainly leukemic infiltration of skin and gingiva. Okay, and you see it right here, looking in the mouth of a leukemic patient. Here's leukemic infiltration of the gingiva. So it's always worthwhile to look in the mouth of a leukemic patient, both because of the mucositis as well as possible leukemic infiltration. Okay. Also, AML patients sometimes can develop quite significant leukostasis with a high white blood cell count. They can develop TIA or a stroke or pulmonary infarctions if those white blood cells get stuck in the capillaries. ALL, okay, lymphocytes love the spleen and love the liver, so you can get significant hepatosplenomegaly. And then specific for all lymphocytic leukemias, in contrast to your myeloid leukemias, is involvement of the CNS system. Okay? And that becomes very important when talking about therapy because those patients require intrathecal chemotherapy. CML, quite significant splenomegaly too. And CLL, splenomegaly lymphadenopathy, is common, but also classically a complex of autoimmune hemolytic anemia, immune-mediated thrombocytopenia, and hypogammaglobulinemia. So a low amount of immunoglobulins. And this again goes into the section of infections, okay? Hypogammaglobulinemia, autoimmune hemolytic anemia goes over to anemia, another cause of anemia, and ITP lastly is a reason for low platelets. So remember, any patient, you always ask about three cardinal symptoms: fatigue, bleeding, infection, and then don't forget about some specific symptoms. After your history and physical exam comes a bunch of laboratory tests. Patients with leukemia undergo many blood tests as well as a bone marrow biopsy. Most importantly, though, to start with is a blood smear. Blood smear looks at the red blood cells, white blood cells, and platelets. And if you see something like this in the blood smear, meaning cells with a big nucleus, a small cytoplasm, what we call a high nuclear cytoplasmic ratio, as well as an area of hypodensity right here, which we would call a prominent nucleoli, then you know those are blast cells. Okay, those are immature cells. Those are the cancer cells in leukemia. Followed, we look at the bone marrow. And we both look at the aspirate as well as the histology in the bone marrow. The aspirate is basically a blood smear from the bone marrow, which is a factory where cells are made. And again, you can see classic blast cells here with a high nuclear cytoplasmic ratio, as well as here you can see actually many hour rods. Secondly, we look at the histology of a bone marrow, which also looks at the environment leukemic cells are in. We look at dysplastic changes, which would point towards MDS, or fibrotic changes, which would point towards an underlying myelofibrosis. It's followed by immunohistochemistry that stains for particular markers that help us figure out what kind of cells those are, as well as, most importantly, flow cytometry and immunophenotyping, which we're going to talk about in a second. All of those techniques help us to first classify leukemia as either myeloid or lymphoid. And secondly, identify a level of maturity. Figure out where are those cells in terms of differentiating down the pathway of hematopoiesis. Their stage in hematopoiesis is going to define what kind of subtype of leukemia they are. And then there are a couple of newer techniques that keep gaining of importance in the diagnostic workup of leukemia. And those are often the most confusing techniques for medical students, interns, and residents, because now it gets highly molecular. We look at cytogenetics, so we look at the chromosomal translocations, and we look at FISH, fluorescence in situ hybridization, as well as we sequence certain genes that we know have a prognostic impact. Those techniques are important for prognosis. Okay? So while the prior techniques were important to identify the subtype of leukemia, those are in particular important to look at prognosis of the leukemia. So let's start with the bone marrow. In the bone marrow, we always want to look at cellularity, blasts, and differentiation. Cellularity, we're going to note, is this bone marrow hyper or hypocellular? We're going to note whether there are blasts or not. And again, remember, blasts are identified by a high nuclear as well as a differentiation ratio. Are there any mature cells that we can see? Are there neutrophils we can see, eosinophils or basophils, or are those mainly immature blast cells? Okay, so here we have two pictures of acute leukemia. This is AML, and this is ALL, acute myeloid and acute lymphoblastic leukemia. Both are defined by greater than 20% bone marrow blasts. Okay, that's a common diagnostic criteria for leukemia. And then you can subclassify the leukemia into AML and ALL. For this, what we use most commonly is flow cytometry and immunohistochemistry. So immunohistochemistry, for example, if we see granules, that points more towards a myeloid leukemia. If we see a positive stain for myeloperoxidase or nonspecific esterase, points also more towards a myeloid leukemia. If TDT gets stained positive, it is more a lymphoid subtype. CML. So CML doesn't have 20% of blasts in the bone marrow, otherwise it would be acute leukemia. But it is a hypercellular bone marrow, and it has all different kind of stages of myeloid differentiation. So we do see blast cells that are having a huge nucleus and a high nuclear to cytoplasmic ratio, but we also see band cells and segmented neutrophils right here. So you see all kind of different stages of the hematopoietic pathway in one single aspirate. That's classic of chronic myeloid leukemia. There are different stages of chronic myeloid leukemia, which are categorized on the amount of blasts you see. If you only see less than 10% blasts in the bone marrow, it's defined as chronic phase. if it's 10 to 20% blasts, it would be CML that is called accelerated CML. And finally, greater 20% blasts define a blastic phase. And a blastic phase of CML is really nothing else than CML that transformed into AML. Lastly, CLL, again SCML defined by a hypercellular bone marrow with more than 30% mature appearing lymphocytes. And you can see the difference between those two pictures, ALL and CLL. Okay, ALL has a lot of big, huge splastic cells, and CLL has a lot of small, mature, finely differentiated appearing lymphocytes. Flow cytometry, one of the most dreaded techniques for medical students, medical interns, and residents. Very confusing. If you get those reports, they say CD34, CD35 positive, CD3, CD7 negative, CD113, CD33 positive, and it goes on and on and on. And all we do is always skip to the end, look at the report, and they will tell us what kind of leukemia it is. Okay? What I want to do here is I don't want to tell you every single marker, but I want to give you at least an idea how flow cytometry works. This is how a flow cytometry machine looks like. Okay, we have our cells here. We have a suspension of different cells. And cells have surface markers. Think of surface markers kind of like as a business card of a cell. Okay, it tells you what kind of cell it is at first. Is it myeloid or is it lymphoid? And it tells you exactly at what kind of development this cell is. Is this a mature granulocyte, or is it a blast cell, or is it something in between? Okay, so that's why we look at markers. Think of markers like business cards. What we do with those cells, we bring them in a cell suspension, and we mix them with monoclonal antibodies against certain markers we are interested in. Then those cells get sucked through a beam of light and a laser. We both have light and we have a laser. Okay, the light detects cellular size and granularity. And depending on how the cells break the light, you can make conclusions about both the size and the cellularity. And then we have a laser too, actually a couple of lasers that can detect monoclonal antibodies that are labeled with fluorochromes. And depending on what spectrum of fluorescence gets admitted, you can make a conclusion of what surface antibodies attached to the cells and what are the surface markers on the cell membrane. Okay, so how does that look like for the light detection as an example? So with light detection, keep in mind, based on both the size of the cell as well as the granularity of the cell, the light gets broken differently. Okay, so we classically have a forward scatter, and you will find cells with increased size more right on the scatter, and a side scatter. And the more cellular cells are, the higher they are on the side scatter. So let's start with our lymphocytes. Okay, so lymphocytes are very small cells, and they have no granularity. So you see them on the left side of the forward scatter because they're small, and you will see them very low on the side scatter because they have no granularity. In opposition are granulocytes. First, they're big, okay? So you will see them on the right side of the forward scatter, and you will see them up on the side scatter because they have a lot of granules. In between, on the forward and side scatter, you will find monocytes. So this is how you can sort different cell populations. And if you get the path report and you want to look at it, this is how it actually looks like. Okay? So again, down on your forward scatter and down on your side scatter are your lymphocytes. Up on the forward scatter and side scatter are big granular cells, your granulocytes, and in between are your monocytes. Okay? And if you use those different populations and label them with antibodies, you can further tell, is this a granulocyte that is a very mature granulocyte, or is this a granulocyte that is an immature granulocyte? Okay, so now let's give you an example how a flow cytometry could work for a patient with leukemia. First, what the lab normally looks at is at markers of immaturity. Okay, and those are normally stem cell markers, meaning they are found on very immature cells. We look often for is CD34 and CD45. So cells get sorted and they get put in a specific tube called the acute leukemia orientation tube. So you know those cells are immature cells, but you don't know are those myeloid leukemia cells or lymphoid leukemia cells. The next step is to look at myeloid and lymphoid surface markers. Classically for myeloid markers is CD13, CD33, and CD117. Lymphoid surface markers depends on whether it's B or T cells. B cell markers are always the higher numbers. It's kind of how I remember it. 19, 22, 79. And T cells are lower numbers. Classic pan T cell markers are the CD3 and CD7. Okay, and you can further obviously differentiate into CD4 and CD8 for helper killer cells. Okay, so that tells you whether it's lymphoid or myeloid. And then we can subclassify the lymphoid or myeloid leukemia based on where the cells are in the stage of hematopoiesis. And both for myeloid as well as lymphoid, there are tons of different stages. So for myeloid, we have a myeloblast, a promyelocyte, a myelocyte, a metamyelocyte, a band, and finally a segmented neutrophil. And all of those different cells have different surface markers. Similar on a lymphocyte, it starts as a very immature lymphoblast and then goes into the follicles of the lymph nodes, and then finally it goes to a mature cell that secretes antibodies. Okay? And again, you can note that on flow cytometry. So, if you get a flow cytometry report now of a patient where it says this is a CD34, CD45 positive population of cells, you know, oh, okay, so those are immature cells. So there must be some blasts there. They are negative for CD13, 33, and 117. You note, oh, okay, so it doesn't seem that they're myeloid cells, but they're positive for CD19, 22, and 79, and negative for CD3 and CD7. You know this is probably a B lineage lymphoid cell. Okay? So this is not Latin to you anymore. You kind of know how to interpret a flow cytometry panel now. So now let's go to the real exciting stuff. Cytogenetics and genetic mutations. Let's start with cytogenetics. What you normally see is a cytogenetic panel that looks like this on the left. And here we again have the CML, the Philadelphia chromosome, between chromosome 9 and 22. And what we find is that a part of one of the chromosomes, 22, is broken off and gets translocated to your chromosome 9. Okay, and then you have a translocation of chromosome 9 and 22. If you label each chromosomal part with fish, you have, for example, 2 chromosomes 22 here and 2 chromosomes 9. And then if you have a fusion between 2, you still have 2 normal chromosomes, but then you have 2 orange spots here where you find a fusion of them. And then you know this is a translocation between 9 and 22, which is classic for CML. Okay? Another example would be a translocation between 15 and 17. So what you see here is part of chromosome 17 goes over to chromosome 15. And you can see that again as PML Ra-alpha, which stands for APL, acute promyelocytic leukemia, on both cytogenetics and FISH. Okay, so normally all patients with leukemia undergo a panel of cytogenetics as well as FISH tests.